Hello, and welcome to our training on ACEs, Adverse Childhood Experiences, and the impact of toxic trauma on human development, health, and well-being. Our presenter today is Dr. Shakir. She graduated from the Aga Khan University in Karachi, Pakistan, and the medical school here at Wayne State University. She is also an assistant clinical professor at Wayne State University Medical School and the medical director at Vista Maria.
Describe CDC Kaiser Permanente Adverse Childhood Experiences Study. Explain impact of toxic stress and adverse childhood events on human development, health, and well-being. Describe risk and protective factors that affect the impact of adverse childhood events. Identify prevention strategies. Describe management and treatment of toxic stress and impact of multiple adversities. Understand compassion fatigue and vicarious trauma. And by vicarious trauma, I mean secondary trauma. I like the term toxic stress. You can use complex stress as well, complex trauma as well. In individuals who have, as part of responding to stress, we all respond a certain way and our brain releases certain neurochemicals. And when it becomes cumulative stress, one after another, or complex trauma, there is the neurochemicals that are released. They are toxic to the body. They cause difficulty in multiple organs as well. And I'll go over that when I'll review the impact of trauma. So this is the background of the ACEs study. Vincent Felici, he started the weight loss clinic in 1980. It was in San Diego. And the reason for starting the clinic was that patients were suffering from health problems such as diabetes, heart attack, and that was worsened by their weight. What they observed was that 55% of the patients quit or dropped out despite success in treatment. So there were patients who weighed 400, 450 pounds in the beginning of the program. And the program was actually designed for patients who were morbidly obese and were somewhere between 400 and 600 pounds, even though patients with lower weight could also join. What they observed was that patients who did come in, who were morbidly obese, did manage to lose weight. The other thing they observed was that none of the participants were born fat. All had normal or below normal birth weight. And when they looked at their weight longitudinally, what they observed was that they didn't really gain weight every year. It was that they would gain weight abruptly and then it would plateau, and then gain abruptly, weight gain abruptly, and then there would be a plateau. And that was an interesting finding. So the puzzling part was that despite success of treatment, why were these patients dropping out? So what they started to do was that they started interviewing patients, and there were about 286 patients who agreed at that time. What they found out was that obese patients didn't really see themselves, their fat or their obesity as a problem. For many, it was a solution. And I'll tell you one of the cases that they had talked about in the article. So as a result of this, they found a link between childhood abuse, physical, verbal, and sexual, and obesity in at least 8% and obesity in at least 8% of the obese population. That means that among 78 million obese and morbidly obese Americans, CDC says exist, more than 6 million overweight people are likely to have suffered physical, verbal, and or sexual abuse during their childhood. The article talks about a very interesting case. This is a woman. Her name is Jan. She starts she started the program. At the start of the program, she was about 480 pounds. And she manages to actually lose about 200, 250 pounds of that weight. And continued to lose weight. But then it was noticed that abruptly she started gaining weight. And when asked, she said, I just don't feel comfortable not being obese. And come to find out, and she was in and out of treatment a few times. And every time it would happen, she would drop the weight and gain it back, and drop the weight and gain it back. When asked, when asked what's going on, she talked about history of sexual trauma. And for her, being obese was a solution. She was not born overweight. She was not obese till the sexual trauma, but started gaining weight at that point. And for her, if she's obese, then she's no longer desirable. And that kept her safe in her mind. Later on in her life, and I don't remember how old she was at that time, she developed pulmonary fibrosis and started losing weight. But at that time, she told the doctor that I'm not too worried anymore because I'm going to die anyways. So I don't have to worry about getting hurt anymore. So when we do see patients who are morbidly obese, very important to find out about a history of childhood trauma. There were other interviews that they did. Some of the patients talked about history of incest. Some of them talked about history of being raped. Even though, as more and more study has been done, and ACE has been looked into other populations, sexual trauma is not the only stressor or traumatic event that causes morbid obesity. It can be any type of trauma. It can be physical, emotional, sexual. So that is the background as to why, it started out as why is it happening that there is a population of patients who cannot tolerate losing weight? So this is a study that was done in 1998, and they looked at relationship of childhood abuse and household dysfunction to many of the leading causes of death in adults. What they wanted to look at was, again, health risk behaviors and its relationship with disease in adulthood. And how is that connected to childhood emotional, physical, and sexual abuse and household dysfunction during childhood? A questionnaire about ACE was mailed to about 13,494 adults. Out of them, over 9,000 people responded. 7 categories were studied: psychological, physical, sexual, or sexual abuse, violence against mother, or living with household members who were substance abusers, mentally ill or suicidal, or even imprisoned. Then the different categories were then compared to measures of adult risk behaviors, health status, and disease. Logistic regression was used to adjust for the effect of demographic factors on association between cumulative number of categories of childhood exposure and risk factors for the leading cause of death in adult life. So they looked at how many of these categories are positive and present, and connected them to, looked at correlation of that with health risk factors in adults. So more than half of the respondents reported at least one, and 1/4 reported more than or equal to 2 categories of childhood exposures. Study also found a graded relationship, as we talked about, between the number of categories of childhood exposures and each of the adult health risk behaviors and diseases. Person who experienced 4 or more categories of childhood exposure compared to those who had experienced none had 4 to 12-fold increased health risk for alcoholism, drug abuse, depression, and suicide attempts, and 2 to 4-fold increase in smoking, poor self-rated health, and more than and equal to 50 sexual intercourse partners and sexually transmitted diseases. About 1.4 to 1.6-fold increase in physical inactivity and adverse obesity. They also found a link with other health conditions like ischemic heart disease, cancer, chronic lung disease, bone fractures, STDs, and liver disease. So these are the different categories that ACE looks at. It looks at physical, emotional, and sexual abuse. It looks at neglect, physical and emotional. And then it looks at household dysfunction. It looks at mental illness in caregivers, domestic violence or mother treated violently, divorce, incarcerated relative, and substance abuse. This is the form. I'm not going to read every component, but it is the first, there are about 10 questions now, the ACE form that we use, or the ACE questionnaire that we use. There are about 10 forms, and they look at the different categories. Every answer that is yes is marked 1, and then the total is calculated at the end. So this is the ACEs pyramid. If you look at that, adverse childhood experiences and, the traumatic stress can happen from conception to death. So a child doesn't have to be, it can happen even before a child is born. And we'll go over that in a second. Adverse childhood events or experiences lead to disruptive neurodevelopment, social, emotional, and cognitive impairment, adoption of health risk behaviors, including substance use, non-compliance or non-adherence to recommendations, and so on and so forth, not taking care of their chronic conditions, disease, disability, and social problems, and early death. Overall, if we look at patients who have severe mental illness, they die on an average about 20 to 25 years younger than our general population who does not have severe emotional impairment. So something to think about. It may have something to do with the disease process. It may also have something to do with adverse experiences. It can have, as I said, lasting effects on obesity, diabetes, depression, suicide attempts, sexually transmitted diseases, heart disease, cancer, stroke, COPD, broken bones, and behaviors, negative effect on behaviors and life potential, graduation rates, academic achievement, lost time from work. And you will, when you see patients, I bet you have encountered patients who have had significant adversities in life, and you meet with them. They're just the kindest people. They're intelligent. And it's wonderful to talk to them. However, they have not really done very well in life. They didn't graduate from school, for example. They're not able to hold a job, and so on and so forth. And I wonder, and I bet you have too, that just for a moment, think about if this person did not have those adversities, where would this person be? And I think it's a very humbling thought, because especially for us professionals who have been able to achieve things in life, to meet somebody who has not been, but potentially had the potential to. I am sorry. Okay. So this is a behavioral risk factor surveillance system, ACE data. Many states are collecting information about adverse childhood experiences through BRFSS. This is an annual state-based random digit dial telephone survey that collects data from non-institutionalized US adults regarding health conditions and risk factors. Since 2009, 48 states plus District of Columbia have included ACE questions for at least 1 year on their survey. They are categorized into two groups: abuse and household challenges. Each category is divided into multiple subcategories. Neglect item was not added until 2019 in the BRFSS. It is in the ACE questionnaire. However, it was not added till 2019. And this is the map as of 2018 about states that have done that. So when these are tables from the ACE study done in 1998 that we talked about earlier. This is from the CDC website. So this talks about demographic information of participants completing the 2011-2014 BRFSS ACE module. I apologize. This is from BRFSS and not the 1998 study. This looks at demographic information. If you look at it, female, male, almost a little bit over female population. Study population is a little bit more than the male population. Most of them are white. Age range, most of them are 25 to 34 or 65 plus. I mean, these are the upper two. And educational attainment, some college is the highest in 32.6% of the population studied. Prevalence of adverse childhood experiences, behavioral risk factors. They look at the ACE scores, and they looked at how many of them out of the population had scored 0, 1, 2, 3, 4. And again, percentages of participants who reported abuse and household challenges. So the trauma tree, I found these diagrams very interesting, and that's why I put them in my presentation as well. This is a trauma tree, and pretty much points out that trauma can happen at any point in life, including prenatal. And then it talks about adverse community, other factors, the pair of ACEs, adverse childhood experiences, adverse community environments. So when we look at stress, what do we really mean by stress? It can be positive, it can be negative, okay? We do need some positive stress in life, right? Why do we need that? Because if we don't have any stress, any anxiety, where would we get the motivation from, right? So it keeps us going. It keeps that drive of moving forward, okay? That's positive stress. Meeting new people, learning a new task, taking SATs, going to school. These are positive stress, and it pushes us towards positive things in life. Tolerable stress include, for example, death of a loved one. Yes, there would be a time where one may feel despair, one may feel sadness, disappointment, anger, guilt, but then there's as time goes by, it heals. And sooner or later, if it is normal grief, life returns back to normal. Toxic stress, however, is cumulative stress. So it is like, many times we give an example of peeling layers of onion. So it is one stress after another, after another, after another. And that is called toxic stress. It can include abuse, neglect, extreme poverty, and so on and so forth. So before I go into effects of traumatic stress or toxic toxic stress, let's go over some of the theories of psychological development and relationships. And then we'll move on to what happens when there is toxic stress. So attachment is an emotional bond with another person. Bowlby believed that the earliest bonds formed by children with their caregivers have a tremendous impact that continues throughout life. This internal voice, everything's gonna be fine, everything will be okay. This confidence, that helps us no matter how difficult a situation is. This internal voice, don't worry about it, it's gonna be okay. Plays an important role in developing our own sense of self. The central theme of attachment theory is that primary caregivers who are available and responsive to an infant's need allow the child to develop a sense of security. The infant knows that the caregiver is dependable, which creates a secure base for the child to then explore the world. Our brains continually form maps of the world, maps of what is safe and what is dangerous. As from the time that we are born, based on our interactions with our external environment, we start building templates of how the world is, template of how to interact with that environment. Because think about it, we are constantly interacting with our environment. There's a constant transition happening. And as this transition is happening, our brain is looking at, okay, this is what's safe and this is what's dangerous. Okay. When a child is raised in a safe holding environment, yes, the templates are going to be more true to how the environment is. It is expected. This is what it is. This is how it's supposed to be. However, it does affect, our templates do get influenced by our experiences, especially if there are adversities. It may cause the template not to be as accurate. Now, this is a diagram of the brain. This is a very simplistic diagram. It pretty much divides the brain in three parts: reptilian brain, limbic brain, and neocortex. Okay. Neocortex is the most recent in terms of evolution layer of the brain. Okay. It is a rational or thinking brain, language. Limbic brain is our emotional or feeling brain, and the reptilian brain is instinctual, right? When a baby is born, primarily is the reptilian brain, okay? It's instinctual, right? It still has to form connections, okay? And develop the limbic system. It's there. I mean, the apparatus is there, but it's not as well developed. And it does need human interaction and appropriate human interactions to develop the way it should be. Around a month and a half, the limbic system starts developing. I mean, I shouldn't say starts developing, it starts developing at birth. However, it continues to develop, okay? And if you look at psychological theories of development, you will see that babies kind of follow a certain timeline. You know, at 2 months, they're going to have a social smile. At 6 months, they're going to have separation anxiety. At about stranger anxiety. Then about 9 months, 10 months, they're going to have separation anxiety. It kind of happens. And if you really look at it, it is it is normal, and it is happening along with the different transaction with other human beings and the rest of the environment that this baby is having, right? And then the last one to develop is the neocortex, our rational thinking brain. Out of that, our executive functioning continue to develop till we are in our 20s. So brain is a social organ made to be in relationship. It is hardwired to take in signals from our social environment, which in turn influences a person's inner world. What happens between brains has a great deal to do with what happens within each individual brain. The me discovers the meaning by joining and belonging to we. This is by Dan Siegel. And I really like the example of the V formation. When geese are flying and they have made the V formation, the purpose of the V formation is actually traveling together with the support of each other. So the first goose is the one working the hardest, flapping the wings, okay? The last ones are really just floating, okay? And they all take turns to be that goose in the front to keep this going, right? And it is all collaborative work. It's all working together. And they trust that it will happen. It will happen in a timely fashion. The first one will not be the only one flapping the wings till the end of the journey. It's not happening, right? And I really like this, and especially when I look at the geese flying, it's just amazing. And next time, observe that, how relaxed the ones at the end are. This is again a diagram from Dan Siegel, and I really liked it. It's colorful and nice. But what it is that non-traumatized young children gradually learn to orient to both external and internal environment, rather than responding reflexively to whatever stimulus presents itself. Okay? Responding reflexively without thinking is more of a reptilian or primitive way of handling things. Okay. Sometimes you may hear patients say, oh, I go from a 0 to 100 and I don't even realize it. I just lose the ability to think. Okay. Now, how do we develop that? How do we go from responding reflexively to actually thinking before acting? It happens through a gradual shift from the right hemisphere dominance to primary reliance on the left hemisphere, and to an integration of internal neural communication across the two brain hemispheres, which is the corpus callosum, okay? So the two halves of the brain, there is a link in the middle, which is called corpus callosum. Actually, children who've had toxic trauma, children who've had multiple adversities, children who've been exposed to substances, alcohol, substances, they too tend to have thinning of the corpus callosum. And research done on development of the brain with therapy, for example, EMDR, has shown that there is gradual thickening of the corpus callosum as the right and the left brain start integrating more. Okay, so practical example would be a person you're treating who comes to your appointment, understands everything you're teaching, right? Has all the right words, goes out but keeps on making the same mistake. Okay, so the learning is not translating in practical. So I know I have the knowledge, I cannot use it to act appropriately. And that is what we see practically in our patients when we evaluate them. So yes, we do have some patients who would just do things to make us angry or, get back at us. But most of the time when we see patients who are operating instinctively, reflexively to their environment, They also have a difficulty translating knowledge to action. Secure children learn a complex vocabulary to describe their emotions, such as love, hate, pleasure, disgust, and anger. Um, it is a very important point. Many times we see children or even adults who've been through multiple adversities. We do see, many patients would say, I don't know how I feel. You ask them, so how do you feel? Sad? Do you feel anxious? Do you feel happy? I don't know. And maybe they may use the word good or bad, the term good or bad. I feel good, I feel bad. You ask them to describe it, it is hard for them. Okay. Feelings vocabulary develop with time as children begin to differentiate among different feelings. Okay. And they begin to look at, okay, if something has happened, does my feeling belong here? So if I get A plus and I'm happy, does that feeling belong there? Absolutely, it belongs there, right? If my pet dies and I'm crying and I'm devastated, yes, that feeling belongs there, and the intensity of the feeling belongs there too, right? So one of the things that is important is in treatment to help children or adults that we are working with to develop a feeling vocabulary. Okay, it's a higher cerebral function, and once we start giving vocabulary to our emotions, to our memories, we start processing it the way we should, right? And once we've processed that, it kind of goes and gets stored in whatever part of the brain it needs to. I mean, I visualize it as cubby holes, okay? And, it kind of gets organized, put wherever it needs to go. Especially when we're working with individuals who have alexithymia or inability to feel or differentiate emotions. So what do we mean by toxic or complex trauma? Trauma is an overwhelming event that causes intense feelings of fear, helplessness, and horror. It is different from stress. Stress is a normal part of life and can be positive and negative. So when can trauma happen? Okay, it can be a result of trauma happening generations ago, epigenetics. And I always give this example when I'm giving a lecture on trauma. I just find it fascinating. Mice that have been taught to fear the smell of cherries when it was paired with an electric shock had children and grandchildren that also showed signs of anxiety when exposed to the odor, even though they had never learned the painful association. Research done on other animals show that the effect of toxic trauma stay in up to the fourth generation. So, and what it is these are genetic changes that happen in as a result of exposure. It can be a good exposure, it can be a traumatic exposure, but here, as we're talking about trauma, those genetic changes happen because of exposure to trauma and adversities. It can happen in the womb if a mother has a history of substance abuse, trauma, toxic stress, or repeated adversity and does not resolve it before becoming pregnant. There is a high likelihood that the mother's biology will have impact on fetal development. Just imagine a mother who has untreated PTSD and is also using substances and is also getting abused at home. Just think about this mother's internal environment where the baby is growing, right? You have all these neurochemicals. Everything that gets released in the body is going to go through the placenta. So you have a mother who has all these neurochemicals floating around. Just imagine how it would affect the baby, mothers who have anxiety during pregnancy. And anxiety actually during pregnancy can be quite toxic. Tend to have babies who their children get diagnosed with either ADHD or an anxiety disorder by the time they're 5. So again, all these chemicals do have an effect on the development of the brain, as well as the rest of the body. Impact of intrauterine substance exposure, it impacts development in multiple areas. Food intake, thermoregulation, sensory system, motor patterns, cognitive development, immune system development, emotional development, and social development. Think about a child who, and that is what I mean about adverse experiences even before a child is born, right? You have a child who's been exposed to all these chemicals and that are affecting overall development and is affecting the development of the organ system. They are born already with vulnerabilities, right? Substances have long-lasting effects. Female addicts are poly users. Men tend to have a drug of choice. Females tend to be poly users. Behavioral problems are often a result of damage to the brain that cause children to process the environment differently. Children and parents have to work together to navigate the challenges. There's really no cure for the damage that they're born with, secondary to prenatal substance use. However, I do feel that when we are working with women who have used substances during pregnancy or have had other difficulties, helping them prepare for a baby who may very well have challenges, all right? And supporting the mom to work with her baby on her own challenges as a mother, and also work with the baby to help the baby with his or her challenges. Now, this is attunement, connection between a mother and a baby. Children who suffer any kind of trauma before their birth have a hard time connecting to their mothers and caregivers. Similarly, parents and caregivers who have untreated chronic illnesses and substance use disorder have a hard time connecting to their child. So think about it. Children are born with limited ability to connect, and parents don't have the motivation to connect. So it again increases the influences of everything else that's happening. I mean, for a baby, not being able to connect to the mom or the attachment figure, and the attachment figure not being able to connect to the baby is quite traumatic. Now, these are some of the childhood adversities, traumatic or adverse experiences, and include living in under-resourced or racially segregated neighborhoods, frequent moving, experiencing food insecurities, poverty, abuse and neglect, domestic, community, and school violence, war, terrorism, refugee trauma, and prenatal substance use. These are definitions of child abuse and neglect. Physical abuse is the intentional use of physical force that can result in physical injury. The term intentional. Sexual abuse involves pressuring or forcing a child to engage in sexual acts. Emotional abuse refers to behaviors that harms a child's self-worth or emotional well-being. Neglect is the failure to meet a child's basic physical and emotional needs. It can be lack of food. It can be lack of shelter, clothing, or a parent might be able to provide everything they can, except emotional reciprocity to the child. So they live in a big bungalow, they have the best food in the world, they have the best room, they can get whatever they want, they have all the high-tech stuff, but the parent's not available to reciprocate emotionally, right? And again, that would be neglect. Rate of experiencing traumatic events, about 25% lifetime. Childhood PTSD, 16%. Acute stress disorder, 14% to 51%. Girls develop PTSD at a rate of 33%, which is much higher than boys. It's controversial if natural recovery occurs from PTSD. It really depends on variables, what kind of an environment this child is in or has been put in. I do feel that as our brain is developing constantly, that putting a child from adversities to a healthier environment does help. Presence of dissociation and hyperarousal predicted development of PTSD. The first 5 years of life have the highest incidence of child maltreatment. And this is summary from different research that has been done. The children this age are more likely than older children to reside in homes in domestic violence. They are not able to keep themselves safe. 75.7% of children who died from child abuse were younger than 4 years. They are disproportionately hospitalized and more likely to die from drowning and submersion, burning, fall, suffocation, choking, poisoning, when compared to children in any other age group. Again, they looked at epidemiology of children who've experienced at least one traumatic stressor in life. About 52.5% of 305 children from age 2 to 5 had experienced at least one severe traumatic stress. Poor and minority children are more likely to report that they experience or witness violence at home. And children from families in poverty have greater lifetime exposure to physical, sexual abuse and witnessing family violence. There is a strong association between the number of stressors experienced by a child and the likelihood of a psychiatric disorder. Children with intellectual disability tend to be more vulnerable to get abused and neglected. The risk factors include varied cognitive abilities, physical limitation, and reduced communication skills, especially if you look at children who are nonverbal. They are more exposed. And when we look at trauma, we're not just looking at intentional trauma as in abuse. It can also happen because of repeated medical procedures and hospitalizations. Any sense of threat that this child is feeling. Children with IDD or intellectual developmental disability, they have multiple caregivers, some of whom may exploit them and cause repeated trauma with long-term consequences. Children with IDD are less likely to be believed because of their intellectual difficulties. So, time for a break. I can answer questions.
Dr. Shakir, I see we have one question in the chat. I think it was
I'm looking.
Referring to the behavioral risk factor surveillance system data that you showed. They asked, there's a high prevalence in groups 64 plus and 24 to 36. Are they correlated generationally?
I would think so, given the age group. Possible, but this is strictly correlational data. Will that give any other information? I'm not sure. So this is L. Johnson, right?
Yep.
Did I answer your question?
Yes, I think so. I was just thinking in terms of certain generations and maybe certain people groups. suffering from environments, outside the family, even outside their smaller communities, from political issues, refugee, if they're,
Absolutely. Absolutely.
and their children,
Yes.
and their grandchildren. So that's
If
where
you look at from epigenetics, yes.
yeah.
If I was to look at this data and connect and look at data from epigenetics, yes, that you're correct. But if I'm just looking at BRFSS, this is strictly correlational data, where there are certain questions that are asked, ACEs is asked, and health risk factors are asked, and there's correlation. It doesn't really look into connecting that with any other generational trauma. Now, it would be interesting that if we were to take one of these groups, like 64 plus, and really look at retrospectively data that would confirm that theory of epigenetics and generational transfer of affective trauma. So
I would think that, for families, refugees coming in and their experience and how that impacts the development of their children and their grandchildren. It's really much more from like a macro point of view, but the outcomes could be measured perhaps in all, the biopsychological and the social domain. So I would be interested in seeing if there are any studies on that, but or if there haven't been, why not? Let's do it.
I think there is data. There is data about that. There is at Wayne State as well. I know that Dr. Javan Bakht is doing research on refugees from Syria and their children, traumatic effect of that. There are researchers who've actually looked at just that effect of growing up in a war zone, for example, or post war, a certain war, and then generations, right? There are studies about veterans who come back from a war, and then how the prevalence of PTSD in their children, and then you see continued effect in the later generations. So one of the studies talked about how if a parent has PTSD, father has PTSD, or has been in combat, there's a higher likelihood for the daughter to have depression, and a higher likelihood of the son to have PTSD. Now, the important thing would be to look into whether it is secondary trauma, okay, or is it primary trauma? A parent who comes in, has PTSD, has a lot of paranoia, is looking at the world a certain way.
Yes.
Is this, and then that affects the child and the way the child looks at the world, and may be traumatic to see dad always hypervigilant, closing blinds all the time. Mm-hmm. So is it direct trauma, or is it vicarious trauma from some of the things that the child may see, or some of the stories the father may tell? Okay.
I have another question regarding
Sure.
the transfer of a traumatic experience, but in utero, especially for females, because of the disparity in job security for women, especially if they get pregnant while they are working. Attitudes of their employer toward them while they are working and they're pregnant, and their sense of security as workers and having a livelihood. And then how do the feelings of anxiety or fear or insecurity that segment about the impact on the fetus? Is there any studies on terms of like all those working women who have children, and then they come back to work the shift in dynamics between how the mother behaves before she's pregnant and then afterwards when she's a mom. How does that affect the mother? And then how does that affect the relationship of the mother to the child and then the health of the child? I realize that's a large question, but it has to do with.
I think you point to an important factor, important variable. Now, I have not, and it doesn't mean there are none because I specifically didn't look at it, or haven't looked at it, but I'm thinking that there would be studies that have looked at exactly what you're saying. Okay.
Mhm.
However, regardless of that, when there is prenatal stress, when there's prenatal anxiety, when there's prenatal substance use, when there is, our brain, all of our brains react in a predictable way. Okay. How we human beings react to trauma is more predictable than we think it is, because we react to any kind of stress in, a certain part of the brain is the sort of the guard of all the information we get. So when we look at amygdala, everything, our environment, everything we get from our senses gets the fastest to the amygdala. And the amygdala is the fire alarm of our brain. So that's going to decide whether this information needs to be processed and then sent to the cerebral cortex, or this is something that I need to act right now. Okay. Now there's another pathway that goes from the thalamus to the cortex. It's a little slow. So it's the same thing. Our amygdala is sort of our intake department. Everything's going to come there. There's going to be screening. It's very fast screening. And I'll give you a simple example. You're walking down the parking lot and you see a car coming 80 miles an hour your direction. Are you going to stand and think what you should do, or will you run? Okay, number one, you're going to run. Second is, are you going to think and run, or are you going to run and think later? We run and think later, because the pathway to our conscious brain, the upper neocortex, is slower. So our brain has already acted. That is instinctual, that's reflexive. So that makes reactions of trauma predictable. Now, again, there are so many different variables that play a role. So an answer to your question is that any kind of stress, there are going to be neurochemicals that will be released, and they will cross the placenta. Okay, and they will affect the baby. It doesn't matter if you have an abusive husband or a coworker who's harassing you at work. Okay, it is stress. All right. So now, as far as specifically working women and the stress they may feel because of attitude of coworkers during their pregnancy, I haven't looked specifically into that. But if you look at it, I'm sure somebody has. Any other questions for me?
I have a quick question. It's something that you mentioned on the slide. I believe you might have been talking about epigenetics when you mentioned that it goes down to like the fourth generation. What were you speaking of again? Was that?
It is. There's another experiment that I know of where they looked at chimpanzees, where they exposed the mom to traumatic events, traumatic exposure. They saw the effect of their trauma up to the fourth generation born. Okay. So whether, now I don't know specifically what symptoms they saw, but hyperarousal, for example, okay, hypervigilance, okay? Because we're going to talk a little bit about as we go that in addition to epigenetics, we also have to look at how our experiences affect the way we shape our life, okay? The decisions we make, right? So yeah, that is what I meant by up to the fourth generation.
Because I'm just really into like intergenerational trauma. It excites me. So I really appreciate this training.
It's like if you are working with patients who have severe emotional impairment, and let's say just look at individuals who've had traumatic experience generation after generation, you see that you're treating somebody with borderline personality disorder and a victim of incest. You get further, okay, mom has your patient's mom had similar experiences. And her mom had similar experiences. So, one wonders that how can incest go generation to generation to generation? How is borderline personality disorder going from generation to generation? Now, there are biological component to the personality disorder, yes. But what else is happening here? How is it shaping our behavior and our ability to sense danger? Individuals who've been repeatedly traumatized, for example, you'll see individuals with borderline personality disorder who've had significant trauma, who've had sexual trauma, for example, and they always find themselves in the same situation again and again and again. Okay. Now, if you look at it from defense mechanism, it's a way of undoing. So this time I'm going to escape before it happens. So intellectually, we can say that. But the other thing is that what happens to the radar? What happens to our ability to then sense danger? Okay. We are born with the ability to sense danger when there's danger, because our brain, safety first, and it's going to keep you safe at the cost of everything else, including making memories, right? So with that, why does it happen that you talk to a patient, you process all of it, and again, they end up in the same situation? So what's really happening here? So there's so many different factors that are playing a role here. From, there's genetic component, there is psychological component, there are, body reactions that we look at. So our implicit memory, explicit memory, there's so many different, it's fascinating how everything comes together. So and especially when you're looking at intergenerational trauma, intergenerational abuse, one of the questions I've always wondered is that if somebody is born in a family of criminals and they become criminals, would that be a disorder, or is it just criminal behavior? And I don't have the perfect answer for that. And I think I'm still thinking about that. But if you really look at it, some of it is genetic and some of it is environment. So, one would want to look at, if let's say this child is removed, and they've done studies on identical twins, and the trajectory is different. So if a baby remaining in the same environment and a baby removed to a safer environment, it's different. Right? So again, some of the behavior, this child with generational criminal behavior is because of the impact of where they are growing. Some of it is genetic. Some of the traits in, let's say, antisocial personality are genetic. But a lot of it is environmental. So removing a child from adversities and putting them in a safer environment is it's worth it. Even though this child may not be perfect, and this child may, it's still worth it, because it will stop that cycle of repeated trauma.
Right. Okay. Thank you so much.
You're welcome. Impact of toxic stress and adverse childhood experiences on human development, health, and well-being. So I'm going to start with talking about window of tolerance. This is a concept that has been introduced by Dr. Dan Siegel. And I really like to use this, helps me visualize. Window of tolerance describes the best state of arousal or stimulation which enables us to function in life. When we exist within this window, we can learn effectively, play, and relate well to ourselves and others. Now, this is the window of tolerance, right? This is where we are self-regulated, we feel emotionally regulated, we're grounded, we're present, alert, flexible. We are in the best sweet spot. We are and we can function the best here, okay? When you move up, that is hyperarousal, fight or flight, anxiety, panic, you feel overwhelmed, hyperactivity, anger, and unable to relax. And when you go down, it is more hypoarousal, exhaustion, feelings of numbness, feeling shut down, depression, shame, poor digestion, disconnection. You know, we often have people who say, oh, I'm just feeling numb, or I cannot, sometimes I feel as if my brain and my body doesn't belong. I feel disconnected. Okay. Now, when we are in our sweet spot, we kind of fluctuate within the window of tolerance, okay? In case of trauma, it can fluctuate, you know, the sweet spot would be window of tolerance. But in untreated trauma, when a person is going through traumatic reactions or reactions to their trauma, they kind of fluctuate between the hyperarousal and hypoarousal. So it doesn't mean that if somebody has a fight or flight reaction because of the trauma, that they won't freeze or have a freeze reaction to the trauma, right? We sometimes see, you know, I work at a residential facility as well, and we often see girls who have had sexual trauma, for example, and they may fight and yell and scream and might need to be physically handled. They may have nightmares at night or feel numb and pee on themselves. Okay, that's again, they fluctuate. Okay, why are they peeing on themselves? Because of that dissociation. Now, dissociation doesn't happen that it's just our consciousness that we are checking out. It can also happen in other ways as well. Chemical imbalance, increase in hormones that help with fight, flight, and freeze, decrease in hormones that help with our physical and mental well-being and help with memory and learning. So if you look at the chemicals, changes in the body because of stress and anxiety, there's elevation of noradrenaline, which can increase aggression, assertiveness, and this is, by assertive, it means more beyond normal, anger, hostility, controlling responses, adrenaline, fear, withdrawal, flight, anxiety, and sleep problems, and cortisol. It interferes with protein synthesis and reduces memory and executive functions. I apologize for the typos. Now, that happens at the cost of chemicals that keep us balanced and regulated. So as the norepinephrine or noradrenaline, epinephrine or adrenaline and cortisol, as they're going up, serotonin, dopamine, oxytocin is going down, okay? And as a result, that affects our ability to stay emotionally regulated. It affects our ability to form relationships, right? And stay alert. So what is being kindled, okay? Being kindled neurobiologically is tendency of some regions of the brain to react to repeated low-level stimulation by progressively boosting neurological discharge, leading to increased reactivity. This is a concept that has been used in epilepsy for a long time, okay? What it is that parts of the brain, they just become sensitive to stimuli. Okay, so the littlest thing is gonna lead to a reaction that is above and beyond. Okay, so a child who, mom asks him what to have for breakfast, he says Fruit Loops, and mom says we have Raisin Bran, and it goes from that to him destroying the living room. Okay, the reaction is above and beyond. I mean, I can understand disappointment, maybe some anger, but the reaction is above and beyond. So again, the reactivity is way above the stimulus. So domains of impairment in children exposed to adverse childhood experiences and complex trauma. So this is a very busy slide. The purpose of this slide is really to highlight that in response to chronic trauma, complex trauma, and not only there is dysfunctional release of neurochemicals, but also it affects the structure of the brain. So reduced corpus callosum size. Corpus callosum, as we talked about, is the area that links the right and the left brain. It causes decrease in the size. Cortical development, that is the upper part, higher level functioning, upper part of the brain, that also affects the development. So trauma can, not just prenatal trauma, but trauma later in life as well, can affect the development of prefrontal cortex, or altering its development and producing precocious maturation but stunted final capacity. What does that mean? So a child who is who's 3 years old has to and has a baby brother who's 1.5, mom is absent, and this 3-year-old has to make a bottle of milk and give it to her baby brother. Okay, now for a 3-year-old, that is really, functioning that's above and beyond. That doesn't mean that there is maturation as well, right, in other areas. So you will see in some children, there is this precocious maturation in certain areas. A sibling, when you talk to children who've been through multiple traumas, I have a child that I talked to that I've been working with. She's 15 and she has an 11-year-old brother. And mom often was homeless. She used to be a sex worker and would often leave the two with unsafe people. And the girl talks about how she took care of her brother in a way that brother became her baby. She made sure that he's fed. She made sure that, he is safe. So if there is harm was to come, it would be to her and not him. So in some ways there you see this maturity, and she's able to talk about that I did A, B, C, D to keep him safe. However, this child has a lot of difficulty regulating emotions, has a lot of difficulty regulating some of her behaviors. She self-harms and shows a certain level of immaturity in her behavior. When normal development is happening, we need to remember that it's a continuum. So from the time a baby is conceived till whenever, it's a continuum, okay? Happens gradually, right? You see development happening a lot faster in the first 3 years of life, but then it kind of, slows down. In situation where there is early stress, there is, the development kind of jumps from one area to another instead of this gradual. So you see this child that you're talking to who's really mature, who can kind of give you the whole treatment plan that this needs to be done and that needs to be done, a couple of hours later is having a fight on the unit on something very little and ends up self-harming. Okay, again, difficulty connecting from knowledge, their knowledge to practical, and then gaps in development. Then again, decreased development of hippocampus. It plays a very important role in memory formation and motion processing. Amygdala, as we talked about, this is a fire alarm of the brain. Just think of it as a fire alarm, or the intake department of the brain. Okay, it plays a role in fear conditioning formation, a recollection of emotional memory, learning of nonverbal motor patterns, triggering of flight or flight response, and control of aggressive oral and sexual behaviors. Amygdala is a very important structure in the brain. All information that we get from all the sensory apparatus that we have goes to the amygdala the fastest. Amygdala decides, okay, is this safe or unsafe? If it is unsafe, I have to act. Okay. The person doesn't have to be consciously aware for the brain to act for survival. And I'll give you an example. And reduce functional activity of the cerebellar vermis. Cerebellum is back of the brain, and it helps with emotional development, attention, language, cognition, and affect, and a lot of other functioning. Okay. So one of the questions that come up is that if a person is sexually assaulted while under the influence of Rohypnol or date rape drug, would they have PTSD? Okay. Yes, they would, because the thing that Rohypnol takes away is our explicit memory or declarative memory, the memory that helps us recall what happened. Okay. But implicit memory that of the event, the body reactions, all the trauma-related reactions are still there. Okay, so you will still see similar reactions. It's just that this person is just not able to recall what exactly happened, but they can still feel their body reactions. So after a child is traumatized multiple times, the imprint of the trauma becomes lodged in many aspects of his or her makeup. So the template that we talked about. So the template ends up getting having all of these imprints embedded in it. Trauma's imprint is both psychological and somatic. Traumatic memories are stored somatically in the nervous system long after the events are over. The body continues to respond as if the danger was still there. This is a quote from The Body Keeps the Score. Being traumatized means continuing to organize your life as if the trauma was still going on, unchanged, immutable, as every new encounter event is contaminated by the past. So it starts getting exhibited in multiple areas of life, okay? Social interactions, sleep, appetite, the way we look at our internal and the way we perceive our internal environment, the way we look at our external environment and process it, the way we interpret cues. Okay, the way we interpret nonverbal language, the way we interpret verbal communication, the way we, and nonverbal cues, as I said. So it just affects overall how we are looking at the world. It affects attachment. So individuals who've had difficulty and multiple adversities have problems with boundaries. They have difficulty trusting, social isolation, interpersonal difficulties, difficulty attuning to other people's emotional state. They just cannot tell how the other person's feeling, and difficulty with perspective taking, being empathic, being able to put themselves in other people's shoes. A lot of biological issues, sensory motor developmental problems, problems with coordination, balance, body tone, somatization, and by that, feeling your emotions in your body. Increased medical problems across a wide span. Pelvic pain, asthma, skin problems, autoimmune disorders, pseudoseizures, COPD, and so on and so forth. Affect regulation or affect dysregulation, difficulty with emotional self-regulation, difficulty labeling and expressing feelings, problems knowing and describing internal states, difficulty communicating wishes and needs. Deficits in the ability of maltreated children to discriminate among and label affective states, the experience of feeling emotions and mood, have been demonstrated as early as 30 months. I talked about earlier how individuals who've been maltreated as children have difficulty labeling their emotions. And this is what it is, and it is exhibited very early on in life. Dissociation, distinct alterations in states of consciousness, amnesia, depersonalization, and derealization, two or more distinct states of consciousness, impaired memory for state-based events. Dissociation is very much part of trauma reaction, especially when it comes to severe trauma in terms of complex trauma, toxic trauma, chronic trauma. And one of the things, though, I caution when I'm talking about dissociation is that dissociation, even though is part of a traumatic, a reaction to trauma, it does not mean dissociative identity disorder. That is separate. It does, yes, it is. When we talk about DID, yes, it is because of dissociation. However, just because an individual is having dissociative episodes does not mean that they also have DID. And very important, because I'm seeing more and more in the community where individuals are being, especially children, are being diagnosed with DID when it is more of a dissociative reaction and not DID as a disorder. Behavioral dysregulation, poor modulation of impulses, self-destructive behavior, aggression towards others, pathological self-soothing behaviors, sleep disturbances, eating disorders, substance abuse, excessive compliance versus oppositional behavior, difficulty understanding and complying with rules, and reenactment of trauma in behavioral play, especially in younger children when they keep on reenacting the trauma. It happens in older children too. Cognition, difficulties in attention regulation and executive functioning, lack of sustained curiosity, problem with processing novel information, problems focusing on completing tasks, problems with object constancy, difficulty planning and anticipating, problems understanding responsibility, learning difficulties, problem with language development, and problem with orientation in time and space. Why is this happening? When individuals are hyper-aroused, they have sympathetic dominance, okay? And what does sympathetic dominance do? It facilitates fight or flight. However, at the cost of what? By decreasing information processing, by decreasing, by negatively affecting our executive functioning, our ability to plan, our ability to focus, our ability to process memories, giving them vocabulary and putting them in the cubby holes, right? Problems with language development. So the higher order functions get compromised because of this consistent sympathetic dominance. So self-concept. Self-concept is described as how a person views him or herself in relation to others. As a result of toxic trauma, there's lack of a continuous, predictable sense of self, poor sense of separateness, disturbances of body image, low self-esteem, shame, and guilt. Okay. One of the things that I have found very beneficial as I'm working with individuals who've had traumatic experiences is really helping them build a sense of self. Okay. Many times I've had women that I treat who may ask, what do you think of me, doctor? Or if you were to describe me, what would that be? Okay. And my answer almost always is, that is for both of us to learn, especially if it is in the beginning of the treatment. Because many times what happens is that when one does not have a good sense of self or self-concept, we kind of take in the labels that everybody is giving us around us, and we try to meet that expectation. So I remember working with a woman who asked me, who do you think I am, or what do you think of me as a patient or as an individual? And as a background, this is a woman who's had a lot of trauma, physical, emotional, sexual, a lot of neglect. And she kind of grew up with, oh, my daughter's borderline, or my daughter's bipolar, and that was the joke. Anytime she would at home show any kind of anger or disappointment, discontent, the predictable response was, oh, mom's having a bipolar moment. And it was to a point where, when I would ask her, so who are you? It would be hard for her to describe that. I don't know. And those diagnoses that she had carried over years kind of became her identity when she was much more than that, right? So that is one thing that, as we are working with patients who've had traumatic experiences or otherwise, very important to help them build that sense of self so that they know who they are, so that they can have realistic expectations from themselves as well as the world around them. Academic achievement. A history of maltreatment is associated with lower grades and poorer scores on standardized tests and other indices of academic achievement. This does not, maltreatment by itself affect academic performance, and also in cases of neglect, in cases of abuse, in cases where parents are not providing a safe environment, a child is constantly in that sympathetic dominance, and it's hard for them to stay focused in school. It's hard for them to learn. It's hard for them to get comfortable with a new teacher in class, right? However, if you do put them in a safer environment, and I see that again and again in children who come from very difficult environments, as I treat at Vista Maria, if they have cognitive impairment, that's one thing, but when they have normal IQ, and they start getting the support in terms of going to school and catching up on stuff that they have missed, they do well, okay? So a lot of it is environmental. A lot of it is educational neglect. A lot of it is being in that hyper-aroused state all the time that doesn't allow them to achieve academically. So understanding the signs. Depending on the age at which you are evaluating the patient, it may be different. In preschool children, fear of being separated from their parent or caregiver, crying, screaming a lot, eating poorly or losing weight. You may see failure to thrive, poor sleep and nightmares, become clingy, loss of previously learned skills. Now, in terms of nightmares, they may see monsters coming after them or monsters coming and hurting their kids. I'm sorry, hurting their parents. So it may not be the same reliving of exactly what's happening at home, but it would be something that may point towards it. In elementary school kids, they tend to become anxious or fearful. They feel a lot of guilt, shame, blame themselves for bad things happening to them or their loved ones. It's always my fault. It's me. My parents fight with each other. It's because of me. My parents are getting a divorce. It's because of me. And many times, when there is dysfunction at home like that, I do talk to the child in front of the parents that, things happen. Things happen, adults make certain decisions and things happen. However, this is not your fault. This is not your responsibility. And one of the things that I talk to parents who are getting a divorce or are divorced is that they do have this conversation with their child that whatever decision they are making, it is because of their circumstances, not because of the child. They have a hard time concentrating, have difficulty sleeping, difficulty learning in school, a lot of somatic complaints, headaches, stomach aches, puking, and then aggression. Middle and high schoolers, self-injurious behaviors, truancy, feeling depressed or alone, develop eating disorders or self-harming behaviors, begin abusing drugs, alcohol, become involved in risky sexual behaviors. One of the things that I always ask, and it is more of a risk assessment as well, that when I evaluate children or teenagers, either substance use or certain risky sexual behaviors, I always ask them, especially about substances, where are they getting it from? If they live in a household where their parents are using, they have it readily available. Okay, they may be sneaking alcohol or they may be sneaking drugs from dad or mom's stash. However, if that is not the case, ask the teenager, how is the teenager supporting the habit? Okay. I do, I'm amazed at how many things are different types of drugs that are available, that can be made available to a teenager in exchange for sexual activity, for sexual favors, for example. I have had teenagers who started using at about 11, 12, 13, and used everything under the sun. I had a girl who had used PCP, marijuana, heroin, cocaine, ecstasy, nitrous oxide, huffing, you name it. But she was also sex trafficked. Many children would say that, oh, but I traffic myself. I post my pictures and I on the internet. That is one thing that, in a gentle way, always ask, how are they getting people to support their habit? And we have to be non-judgmental in that. There is this whole process that is going on where this child is acting out. What is this child trying to escape? Is that her own depression, or is that situations in the house, and so on and so forth? Okay. Become involved in risky sexual behaviors. Access to information, access to the internet, it's a blessing, but it's also opens doors of information that is not age appropriate for a lot of kids. And it has opened doors to get for perpetrators to connect with minors and for minors to get taken advantage of. So adaptation to complex trauma and familial context. The response of the child's social support system, and particularly the child's mother, is the most important factor in determining child's outcome and is more important than objective elements of the victimization itself. Caregiver support is a critical mediating factor in determining how children adapt to victimization. There are three main elements: believing and validating their child's experience, tolerating the child's affect, and managing the caregiver's own emotional response. When a caregiver denies child's experience, the child is forced to act as if the trauma did not occur. The child also learns he or she cannot trust the primary caregiver and does not learn to use language to deal with adversity. I'm always amazed, us parents, I think we have to be very careful with our children, without realizing we may be gaslighting them. It does make a difference if a child comes to you and says, "Oh, I fell and there's a boo-boo, it's bleeding." Mom's response could be, "Oh, come on now, there's nothing there, come on." Or, "Oh, let me take a look at it. Let's clean it up. Let's put Band-Aid on it. Let me kiss you there. It's gonna be fine. You can go out and play. It happens." Such a huge difference, okay? We do need our adults, as we're growing old, as we're getting older, is to validate our experiences. I mean, how else am I going to learn if I'm right or wrong? Okay. And sometimes you see adults who've not really had accurate validation, that they kind of stay in this ambivalent state. Yes or no? Am I pretty? Am I not? Does this dress look good? Oh, I don't know. Let me ask somebody. And they're just not able to trust their own experiences, their own perception of the environment. Ethnocultural issues, the threshold for defining a complex trauma reaction as a problem warranting intervention, differs not only across national and cultural groups, but also within some.
I know what it is.
Okay, so when we talk about ethnocultural issues, the way trauma is perceived in different culture, I think as a clinician working with individuals who've had traumatic experiences, who've had certain adversities, let the patient, let the person you're working with explain to you how they perceive it, especially in the light of the environment they grew up in. Okay, it doesn't mean that trauma in one part of the, and let me give you a specific example. Rape in one part of the world would not be rape in another part of the world. No, it does not mean that. What it is how is it being perceived? Because it does affect our ability to, the way it affects the way we handle it. It affects the way we process it. It affects the way we bring it up in treatment. So something important to understand. Key trauma-related constructs may be perceived and understood differently. Like flashbacks may be visions, hyperarousal may be a thought de nerveux, dissociation may be the spirit possession. So I'm going to go over some risk and protective factors, individual and family risk factors for adverse childhood experiences. Include family experiencing caregiving challenges related to children with special needs, children and youth who don't feel close to their parents and they feel that they cannot talk to them about their feelings, youth who start dating earlier, engaging in sexual activity early, children and youth with few or no friends or with friends who engage in aggressive or delinquent behavior, families with caregivers who have a limited understanding of children's need or development, families with caregivers who were abused or neglected as children. Again, we learn from our adults, and that is what we teach our children. If I don't know how to parent, there's no manual of ideal parenting. It's a transaction between you and your child, right? And if I don't have the right ingredients, it can affect my ability to parent. Families with young caregivers or single parents, families with low income, families with adults with low level of education, families experiencing high levels of parenting stress or economic stress, families with caregivers who use spanking and other forms of corporal punishment, inconsistent discipline, families that are isolated and not connected with other people, families with high conflict and negative communication style, and families with attitude accepting of or justifying violence or aggression. Community risk factors include communities with a high rate of violence and crime, poverty and limited education, economic opportunities, unemployment, high unemployment rates, easy access to drugs and alcohol, neighbors who live in silos and don't interact with each other, not enough community activities for young people, unstable housing, food insecurity, and higher levels of social and environmental disorders. Individual and family protective factors. Families who create safe and stable and nurturing relationships, meaning children have a consistent family life where they're safe, taken care of, and supported. Many times, just sometimes it can happen where a parent cannot love a child, okay? And that creates a lot of guilt. It's my child. How can I not love my child, okay? Sometimes it is hard for parents. Just imagine a parent who herself has an attachment disorder and has had her own adversities and now raising another human being. Just imagine all the dread and all the turmoil it brings. One of the things that I do talk to them about is that in order to be a safe parent, you may or may not love your child, but you can still be a safe parent. Okay, just think about being a safe parent, a safe guardian for this child, so that you can help this child stay safe and develop in a safe environment, a holding environment, okay? Love may or may not come, but at least this child will be safe, okay? Children who do well in school have good friendships, peer network. Children who have caring adults outside the family who serve as mentors, like, some children develop a good relationship with their teachers. Families where caregivers can meet basic needs. Caregivers who have higher education, caregivers who have steady employment, strong social support, positive relationships, caregivers engaging in parental monitoring, supervision, and consistent enforcement of rules. Consistency, predictability is very important while raising a child. And so on and so forth. Ability to help, or not just ability, but willingness to help your child work through problems. Community protective factors, again, economic and financial help, access to medical care and mental health services, safe and stable housing, access to nurturing and safe childcare, high quality preschool, and so on and so forth. A community which takes care of the needs of the people that form that community is a safe community that nurtures safe families, who nurture children who are developing, who are able to develop the way they are intended to. Again, this is a repeat of this is another slide. It is from National Child Traumatic Stress Network, a very good website if you want to explore. Again, the way one would react to traumatic stress would depend on severity of the event, proximity to the event, caregivers' reactions to the event, or the child's experience, prior history of trauma, and family and community factors, as we talked about. Preventing ACEs, these are some of the strategies: strengthening economic support to families, promote social norms that protect against violence and adversities, ensure a strong start for children, teach skills, social emotional learning, connect youth to caring adults and activities, for example, mentoring programs, and intervene to lessen immediate and long-term harms. Across CDC technical packages, there are several strategies that can prevent ACEs from happening, as we talked about, as well as strategies to mitigate the harms. So, any questions?
We do have one in the chat from Elizabeth.
Okay. And we can continue with the presentation, or we can take another break, whatever everybody thinks. Could a pre-adolescent who posed their pictures to obtain substances through sex be understood as the child's effort to exert agency over their own supply? If the behavior is embedded in early, what diagnosis and treatment would be considered to address the core issues? So first of all, if a child is indeed posting her own pictures and somebody is taking advantage of it, especially an adult is taking advantage of it, that is by definition would be a form of sex trafficking. Okay, so when we talk about sex trafficking, it needs to, in order to prove that there's trafficking and not willing behavior happening, we do need to, by law, prove force, fraud, and coercion. Okay, unless it's a child who's less than 18. Okay, so this child, no matter what they say, I'm prostituting myself, I am getting my own clients, I don't have a pimp, so on and so forth, is still being trafficked. Okay, now, for whatever it may be, for in exchange for drugs, it can be exchange of emotional support or whatever. It would come under sexual trauma, sexual assault, trafficking. Okay, so how would you diagnose and treat to address the core issues? It really depends clinically on your evaluation. Okay, there is a higher incidence of children who get sex trafficked or even sexually assault other children, with, there's a correlation between that and adversities in life. Incest is a very big risk factor for that. So as we are looking at, getting a thorough history, does this child meet what diagnoses this child meets? Okay, and treatment would be accordingly. Okay, again, like any kind of high-risk behaviors, a child who is posting nudes on the internet, it would be the similar strategies that we would apply. Help them understand what's really leading to this. What are the triggering factors? What is this child achieving by this? And then teaching them alternative positive ways. Okay, so these are all coping techniques that a child is using, whether it is cutting, drugs, being promiscuous, posting nudes, you name it. Okay, and why do children act out? Children act out to defend against emotional discomfort, right? So what is uncomfortable? Now, I think when we tell a child, you shouldn't do that, that's wrong. Okay, but am I giving them an alternative? So the next time my mom yells at me and shows me the belt when I bring a B+ home and it's not A+, and my coping is having, my coping is sexting. If I don't do that, how do I cope? Because that sexting is serving a purpose in that moment. So one of the things that I do ask, when we are talking about coping skills that are unsafe, right? What does it do for you? In the moment, what does that do for you? So when you post pictures, what does that do for you? I get a compliment. Okay. And so tell me about the significance of that compliment. My mom never appreciates when I bring good grades. At least this person who I don't know has something nice to say about me. Okay. We all we are social beings, right? We are born in a world full of people, whether we like it or not. And we thrive with social connections, okay? We do need validations from our environments, no matter how secure we are inside, okay? Whether we validate ourselves, whether we seek validation from the environment or the people, but we do need that, right? So for a child especially, and I say both, by child, I mean both children and adolescents, any attention is meeting a need, okay? That is better than isolation, okay? And isolation is very painful for human beings. So instead of feeling isolated because I don't have anybody at home who appreciates my good work, I'll do this. At least somebody appreciates. At least I'm able to do something that somebody's finding, even though I know it's risky, even though I know it's harmful, even though it causes dysregulation in me, but it's serving a purpose. So always ask when they are using substances or they are cutting or whatever, what purpose did it serve in that moment? Okay. Because if you some individuals some children may say, I don't know what I was feeling. And that's true, because many times when children are exhibiting self-injurious behaviors, they dissociate. Okay, so they're feeling numb, they're dissociating. So no, they will not be able to tell you how I was feeling in that moment when I did it. There's a good possibility they won't. But they will tell you, though, what purpose did it serve? I was feeling so numb and disconnected that once I cut, I could feel, and it brought me back. So is this child using cutting as a grounding technique? There are much safer things to do to ground, right? So I know it's a very long-winded answer to a straightforward question, but I think that all of that would be included, all those. Yeah.
Any other questions?
I'm going to make a brief comment statement. But as I started working on, myself, healing my own childhood trauma, et cetera, I see how important it is for a child to be validated. Like, it's the small things that mean so much. And I personally believe if parents can simply make their child feel seen, heard, understood, and just accept them, that can do wonders for a child. It's the basic things. It's not even that complicated, but it's the little things that people don't seem to understand. And that means love to a child.
Yes.
Because you can provide.
Love never spoils.
Yeah.
I strongly believe that love never spoils. When we substitute love with material things, that's what spoils.
Yeah.
Love by itself doesn't.
Yeah.
And, when you are working with parents, ask them how they feel about their children.
Mhm.
Okay, because when you're working with a woman who conceived as a result of a rape,
Yeah.
how does this person feel? How
Mhm.
does this person feel raising a child who's getting older and looks just like the rapist?
Mhm.
How does this woman feel? Now, what difficulties is this woman having now validating her child? Okay, so we have to show compassion to the child and also to the parent,
Mhm.
because it's like, if I have an empty wallet, I won't be able to give you any money. The
Right.
same thing is that when we are working with parents, then you fill their trunk of basic needs so that we model that behavior with them, and they then can show it to their children. Because think about it, a lot of these parents have not been validated. So
Right.
they don't know what they're doing is right. So if a child says, in fall, it's beautiful, and the child says, oh, a red leaf, mom can say, what are you talking about? All of it is green. Or, you're right about that. What other colors can you see? So the difference would be validating as well as expanding.
Yeah. Yeah. And this is the last thing, and I don't know, maybe I need to talk to you about this later, but I'm in the mental health nurse practitioner program, and I desire to work child and adolescents. That's my heart.
Mhm.
Can you give me one word of advice, or do you want me to chat with you later?
We can chat later, absolutely.
Okay.
Absolutely. But just remember that whatever experiences you have with your patients, every patient's going to teach you.
Mhm.
And that's going to go in your toolbox.
Okay.
There is, no matter how difficult, no matter how easy the patient is. And as you're connecting with the patients, it's going to build your sixth sense, intuition, right?
Yeah.
So
Thank you.
no problem. So it's up to you guys if you want to take maybe a 5-10 minute break and come back, or I can continue, whatever you guys prefer. So we're going to move on to talk about trauma-informed care. Okay. Trauma-informed care recognizes and responds to the signs, symptoms, and risk of trauma to better support the health needs of patients who have experienced ACEs and toxic stress. One of the most important thing about trauma-informed care is it is patient-centered, okay? It's not a set of principles that we're going to impose on a patient. We're going to meet them where they are, okay? So there are 6 trauma-informed core principles: safety and stability, first and foremost; cultural humility and responsiveness, compassion and dependability, understanding trauma and stress, resiliency and recovery, and collaboration and empowerment. So if a person is in an abusive relationship and going on 1 year now, every time this woman comes and has a black eye, your response can be, how many times do I have to tell you to leave him? Or you support, you ask about safety, you help the person reach a point where they're ready to leave. In the meantime, you're going to help the person, help your patient do the best they can, given their emotional stability as well. Okay, because there's this whole concept of trauma bonding that happens, which makes it very hard for somebody who is being abused day in and day out to leave. It's very hard, and there's so many different variables involved. But our job is to meet our patients where they are and help them there. Many times it happens, let's say, in the emergency room or outpatient care, where it's just very frustrating, and it can cause a lot of burnout if we keep on seeing the same person coming in with the same kind of issues, and they are just not, quote unquote, listening to us. It's not about that. and if we can have, it's not just about saying that meet the person where they are, it's really developing a mindset of it. Okay. TIC framework, understanding the prevalence of trauma and adversity and their impacts on health and behavior, recognizing the effect of trauma and adversity on health and behavior, training leadership, providers, and staff on responding to patients with best practices in trauma-informed care, integrating knowledge about trauma and adversity into policies, procedures, practices, and treatment planning, and resisting re-traumatization by approaching patients who've had experienced ACEs and or other adversities with non-judgmental support. And that is what I meant, that, our agenda and the patient's agenda when it comes to helping the patient may not be the same, but we need to still support what the patient needs in that moment. So mitigating the effects of adverse childhood experiencing management and treatment strategies. Timely access to assessment, intervention, and effective care, support, and treatment for children and families in which ACEs have already occurred can help mitigate the health and behavioral consequences. Strengthen children's resilience and break the cycle of adversity. Many times it does happen where we may see generational trauma happening, okay? And 1 out of the 4 kids decide, okay, time for change here. I don't have to repeat the history. I don't have to do things the way they have been done generation, and we support that. We help them with that, and there starts the next generation, a healthier generation, okay? So every person, every patient counts. Every family counts. So if you're working with a family and a family is, willing to bring positive changes, good. But if the family is not, is there one of the kids? We work, especially I've observed that in residential, in the residential facility I work at, that sometimes, as the girl is working on her own trauma and her own adversities in treatment, and developing a sense of self, she may be the only one who may be able to break the cycle that the family has had for generations. And that's okay. One person at a time, it's okay. And sometimes, what the support they need is really validation. That I understand your parents didn't get education. I understand your parents still drink. However, you can make a different decision, and it is okay to make a different decision. It does not make you less of a child to your parents. You still belong to the family. It is just that when you bring positive changes, it will be better for your life and your future. Treatments to lessen harms caused by ACEs, referral to behavioral health services, pharmacologic treatment, trauma-focused psychotherapy, such as TFCBT, EMDR, etc. When we do make referrals, sometimes, especially children or even adults, especially if they have had unfortunate circumstances and they've had involvement of foster care, social services, child protective services, so on and so forth, they already have a mistrust of providers, okay? Don't take it personally. It is going to be there because in their mind, they got hurt by that. Either you may see both reports. You may hear both reports. I have some children or adults who would say that I got ripped away from my family. I did not want to leave my parents. And I actually worked with a child who kept on running away to her mom. And it was unfortunately a very unsafe environment. Then you have children who complained that they kept on asking for help. They kept on calling Child Protective Services or letting adults know what's going on, but their parents were too savvy. They could they fooled the Child Protective Service worker. Oh, my dad was a charmer. He did that. Again, mistrust, because even though I asked for help, I didn't get the right kind of help. Then treatment to prevent problems and family-centered treatment approaches. Monitoring and evaluations are necessary components of the public health approach to prevention. Behavioral risk factor surveillance system, BRFSS, 18 and older, youth risk behavior surveillance system, YRBSS, National Survey of Children's Exposure to Violence, the National Intimate Partner Sexual Violence Survey, the National Survey of Children's Health, and the National Crime Victimization Survey. The National Child Abuse and Neglect Data System provides official reports of child abuse and neglect made to Child Protective Services. The National Violent Death Reporting System is a state-based surveillance system that combines data from death certificates, law enforcement reports, and coroner or medical examiner reports to provide detailed information on the circumstances of violent deaths, such as homicide and suicide, including intimate partner violence, mental health problems and treatment, and recent life stressors. Information about violent offenses, victimization, and involvement with the justice system are also available from the Department of Justice's Bureau of Justice Statistics, the Federal Bureau of Investigation's Uniform Crime Reports, and the Office of Juvenile Justice and Delinquency Statistical Briefing book. And you can go on the website, and if you're interested in pulling up reports, you can. What can parents and caregivers do to help? A strong relationship with a parent is one of the most important factors to help a child heal and grow in a positive direction. These are some of the websites that you can go to if you want to learn about trauma and its impact on children. Three main elements in parents and caregivers' responses to their children's trauma. And I mentioned that earlier as well, and this is just a duplicate. Believing and validating their child's experience, tolerating their child's emotions, and managing the caregiver's own emotional response. When a child is worked up, okay, and they are either hyper-aroused, yelling, screaming, in that stage, they cannot tolerate another person yelling and screaming. And that is why many times you would hear the parent and the child going on and on and on and on, and the argument is going up and up and up and up. One thing to remember that as especially children who've had adversities, or individuals who've had adversities, when they are worked up like that, it is very important for us to talk in a low tone, okay? Raising the voice, they're not gonna understand. All they're gonna hear is the tone of your voice. Then they're not hearing or processing the words. Talking in a low tone and slow is actually gonna get the point across. They'll be able to register it. It's just the way our brain works. Recognizing your child's strengths. How many times we very readily point out our children's limitations. Many times we see at the clinic where sometimes, parents cannot even tolerate a single compliment to their child. You go and say, hey, I like your hairstyle. And the parent would immediately make a comment about how bad they're doing in school. Let the child enjoy the compliment, right? When we are working with parents who are having difficulty acknowledging their child's strength, ask them, Is it that they grew up in a home environment where acknowledging strengths and positive attributes was considered as spoiling? Okay, so if you give a compliment, somehow you're going to praise is going to spoil the child. So no, you don't give children praise, or other, even expression of certain emotions. Some cultures may not allow their um, um, male offsprings to express emotions a certain way, certain emotions, certain behaviors related to the emotions kind of get divided, that this is what a girl is allowed and this is what a boy is allowed, right? So again, recognizing your child's strengths, ability to form relationship and friendships, ability to recognize and verbalize emotions, ability to learn, ability to tolerate frustration, self-confidence, motivation to act effectively in one's environment, effective coping strategies, ability to function independently, special talents and creativity and spirituality. Okay. Even children who are misbehaving and are defiant, many times it is because they are not getting positive attention. Attention is important to a child, okay, positive or negative. However, if a child is getting positive attention from their caregivers, parents especially, they will try to maintain that. They will choose that positive they will choose that positive attention over negative attention. Try to help the child understand the trauma. Pay attention and be good listeners. Allow them to ask questions. Encouraging healthy activities. Letting your children know that they are not to blame when bad things happen. Try to exhibit your anger and disappointment appropriately. Model the behaviors you would like the child to learn. How can we yell and scream and expect our child not to do that? I mean, if I'm yelling and screaming or I'm spanking, how can I tell my child not to yell and scream and hit, right? So we model behaviors. Children learn from our behaviors more so than what we teach them with words, okay? So as we are modeling behaviors, they learn, okay? Sometimes when I'm working with parents and they are quick to react, and sometimes they say it's just so frustrating to just zip it, because at that time I just want to cuss him out. Okay, just zip it and know that you're going to come next week and see me, right? We'll talk about it then. You do have a way to an outlet, and if it becomes an emergency, call me. But try as much as possible not to get in that power struggle. It's very hard to work with parents who cannot let go of that. I mean, they always have to have the last say. They always have to have, they expect everyone around them, especially their children, to have the perception of the world the way they have. And they're not tolerant to accept differences in their children. It's very hard to work with the parents who are not ready to make that change, make a positive change. Keep the doors of communication always open. Children may not talk to their caregivers at the time when they're overwhelmed. However, knowing that they can always go to their parents or caregivers give them the confidence to reach out when they're ready. Okay. Just like we do when we are really worked up, either the wrong things are going to come out of our mouth, or we just are not able to find the words. How many times it happens when we're upset and we cannot find the words to express ourselves? It's biological, neurological. It's not something that we're doing willfully, right? The same way as we need to process that, some people need to process, some people need to say it and vent, okay? So all children are different. They may not, they may need some time to process, and they will come. If they trust that they can come to you and you will listen to them non-judgmentally, They will come to you. That does not mean that you have to let go of limit setting. That does not mean that you have to say yes to everything they're talking about or asking. Okay? If they have made a wrong choice, then that is a wrong choice or a bad choice. It is. So listening and being empathic to the child does not mean that you're going to blindly agree to whatever they're asking for. It means that you're going to be non-judgmental. That's going to open the doors of then a communication, a dialogue of alternative ways of doing things, right? Open, honest, and age-appropriate communication with your children. If a child asks a question, they're ready for an answer. The key is giving the answer in an age-appropriate manner. So most children are attuned to their parents just the same way the parents are attuned to them. What it means is that they can tell when something is not right. Having honest and open age-appropriate conversations help children build trust in their parents and caregivers. Pay attention to your child's cues. Children with history of trauma often have difficulty processing the sensory input. In other words, the brain has a hard time working with information it's receiving from the different senses. Some children may have difficulty with certain smells, food, sounds, texture of clothing and food, taste, touch, balance, and body tone. Many children wiggle or rock to help themselves get oriented to the environment. They are not trying to be difficult by moving or fidgeting. They need to do that to reorient. Children who have ADHD and they fidget, some of the fidgeting is their effort to reorient and get focused. Some children are always seeking stimuli, and some cannot tolerate even a little. Children with history of traumatic stress are always watching their environment and may get triggered by something seemingly benign and harmless. Having a calm and peaceful environment that provides optimal and healthy stimuli to the child can help your child have better control of his or her behavior and expression of emotions. Working with the school system. Children with history of trauma often have social, emotional, and academic difficulties. They often have difficulty with speech and language and taking care of daily occupations. Working with the school to help get support and services for your child in school is very important. As I talked about, children who have had either prenatal trauma or since early childhood trauma, they may have language difficulties. They may have difficulty with coordination, their gross motor or their fine motor. Working with the school or working with the therapist to get those services is very important. Getting mental health treatment for your child. Appointment with the pediatrician or family physician at least yearly and when needed. And that is a very good checkpoint in a child's life, okay? When they do go to see a primary care physician or the pediatrician then has an opportunity to talk to the child and make sure that the child is safe, that the child feels safe at home, that the child feels safe in school and the community. And at that point, again, with a health professional, that screening done at least yearly is very important. Part of taking care of your child is taking care of yourself. Be aware of your own feelings and reactions, taking care of yourself the best way you can. Keep other family members and important adults informed of your child's needs. And do not hesitate to seek professional help. Sometimes it happens when we are working with a disruptive child and the parent is having a lot of difficulty. And we start observing that they probably need help as well. Starting a conversation about that with the parent. There's no harm in that. Many times, as it doesn't have to be on the same day that you see the child with the parent, you can let the parent know that I would like to see you. And why don't we make a parent appointment in a couple of weeks? Have the parent come in and inquire. Again, non-judgmental. This parent may come and talk a certain way about her child, let her, but then see, help her also see if a lot of these perception of her child are being influenced by her own affective state. Okay. And recommend and help. You can recommend treatment, you can recommend referrals, because we see children, maybe if we are doing therapy for an hour a week, maybe an hour every other week, this child is going back to the environment of the home. And it's the home environment that needs to model and continue the work that we are doing in the office. So I'm going to take some time to talk about compassion fatigue and vicarious trauma, how to take care of our own mental health. And this is for providers while working with survivors of ACEs. It takes a toll. It takes a toll. I remember when I was a resident and a fellow, I enjoyed, and I still do, working with patients who had borderline personality disorder, kids with ODD, conduct disorder. And, in my mind, when I see a child who has ODD or conduct disorder, there's this twinkle in their eye of, I can do anything and you can't do nothing about it. It's just fascinating to me, that irrational self-confidence, so to speak, or egocentricity that should have been taken care of a long time ago developmentally. And it's quite interesting. So I remember one of my supervisors saying, there's just so many patients with borderline you can have. Don't think that you can handle each and every one of them. And at that point, I was like, oh, come on now, I love doing this. But yes, it takes a toll. It does come to a point where you just don't want to. And you don't want to bring yourself to that point. You want to keep that drive going. So compassion fatigue is a condition characterized by emotional and physical exhaustion leading to a diminished ability to empathize or feel compassion for others, often described as the negative cost of caring. It is sometimes referred to as secondary traumatic stress or vicarious trauma. Compassion fatigue has a more rapid onset, while burnout emerges over time. And if recognized and managed early, compassion fatigue can recover, has a faster recovery. So what are some of the symptoms of compassion fatigue? It affects many dimensions of your well-being: nervous system hyperarousal or arousal, sleep disturbance, emotional intensity increases, cognitive ability decreases. So these are all signs of hyperarousal. Behavior and judgment is impaired, isolation, loss of morale, depression, PTSD. Sometimes if a caregiver has his own history of trauma, that can get potentiated. Loss of self-worth and emotional modulation, identity, worldview, and spirituality is impacted. Loss of hope, meaning, feelings of despair, disappointment. Many times it happens where you just get in the habit of booking 2 extra patients. And just because you have kind of maybe 2 or 3 no-shows. And it builds up because your patients will show. And then it gets to the point where you're like, oh my gosh, I hope Mrs. So-and-so don't come. I just don't have the mental strength to tolerate that, right? Or you develop a certain, you fail to recognize your countertransference towards the patient. You may react a certain way towards a patient. So very important to be mindful of how our reactions are towards our profession. So I really like this curve, Yerke-Dodson law. What it really is, and it can be applied to muscle strength, it can be applied to our affective state or the what it is it's a relationship between pressure and ability to cope, okay? So when you look in the middle of this bell curve, this is the sweet spot in the middle. This is where functioning is optimum, okay? When it goes from not really being involved, frustration, boredom, it goes to stimulated, alert, decisive, creative, and effective, okay? You push yourself more, it starts reducing your endurance. It starts reducing your ability to perform, your efficiency, okay? So as much as possible, and ideally, we want to stay here in our optimum sweet spot in the middle of the curve, okay? So that and for that, we need balance. So again, this is a compassion fatigue process, starts with an empathic response, which, if not watched, leads to residual compassion stress, and then to compassion fatigue, okay? And when there's compassion fatigue, it's not only the work that gets affected, other areas of your life get affected too, including other relationships outside of work. So tips for managing compassion fatigue: find someone to talk to, understand that the pain you feel is normal, exercise and eat properly, get enough sleep, take some time off, and develop interests outside of medicine or whatever your field may be, and identify what's important to you. Prioritizing, okay? Again, it's the same thing we tell our patients, right? That in order for you to take care of others, you have to take care of yourself. Another example many times people give is, when we get on the airplane and they're giving the initial instructions, they tell you to put your mask on first before you put it even on your child. Why is that? Same thing. If I'm depleted, how will I be able to help others, including my family? The don'ts are blaming others, displacing blame, looking for a new job, buying a new car, getting a divorce, or having an affair. That happens in some professions. And especially if you have a feeling that, oh, but I just totally loved this field. I just loved my patients. I don't know what's happening. Step back, see what's happening. Maybe it is just you have too much on your plate and you're not able to bring a balance. Fall into the habit of complaining with your colleagues. Hire a lawyer, work harder and longer, which is, of course, going to make things worse. Self-medicate and neglect your own needs and interests. I find this part, hiring a lawyer, in this list quite interesting. I got it from a paper, and I chose to include it just because I found it interesting. The ABCs of preventing compassion fatigue, the American Institute of Stress, stress.org, they have very good resources. So there are 3 components: awareness, balance, and connections. So awareness includes 2 questions. What types of cases contribute to your stress level, increasing your vulnerability to compassion fatigue? Think of events or situations that cause you to experience a strong reaction and overpowers your ability to cope normally. Okay, what are some of those situations? Okay, what are some of those situations that overwhelm you? And there's no harm in saying, I cannot do this, but I can do this. Okay. Especially as we graduate and we are thinking about what direction we want our profession to take. It is okay to say, I'm not going to treat this, but I'm going to treat this. I'm not going to handle this, I'm going to handle that. I mean, many of us choose to work, some of us choose to work in a residential facility, some inpatient, some nursing homes, some private practice, some academics, right? So again, knowing what brings out that sense of achievement and efficiency without compromising other areas of your life. and awareness of issues that are contributing to compassion fatigue. Paying attention to ability to function is interfered with or altered. Situation or incident does not seem typical or ordinary. It feels traumatic. Sometimes you will have individuals, patients, or even yourself may feel that, oh my gosh, going to work is becoming traumatic. Compassion, stress, or fatigue break through normal boundaries. You wake up tired, you go to sleep tired, you dread a new day. Every day you're thinking about, okay, I have, 6 days left, let me take one. Losing compassion for people, feeling bored or disgusted, and experiencing body, somatic symptoms. Balance. Keeping balance in life is important. And we can do that by nurturing ourselves, putting everything in a balance. I mean, think about how many areas of our life that we are taking care of simultaneously. Ourselves, work, children, spouse, friendships, parents. What if you're pregnant? What if you're preparing a lecture? So many things that we take care of simultaneously that we don't realize. Finding a balance in that. It's okay if you're somebody who likes to read something related to your profession every day, and one day you don't feel like it and you just want to pick up just any book that doesn't make you think, but just, help you relax. Go ahead, do that. We don't have to be compulsive. Balancing exercise. List one mini escape or diversion that works well to restore and renew you. One thing that brings you joy. Help you feel things that help you feel grateful. Think of something that has brought you a sense of joy in the past, identifying things that are going to bring that balance. For me, I love music, and I go from genre to genre, and that is one thing that really helps me get grounded. So if I am feeling all over the place, and sometimes it does happen where I'm trying to do 10 things at the same time. Unfortunately, that's a flaw. Just taking a break and listening to music grounds me and relaxes me enough that then I can prioritize and put things and organize things in a way that they are more manageable. Because anytime we are stressed and we feel like, oh my gosh, I'm being pulled in multiple directions, it's hard to prioritize till you actually step back, ground yourself, and then reprioritize. Finding a passion. We all have hidden sources of energy and healing power. When we identify things that fuel us, the things that we have true passion for, fatigue will disappear. Things that you enjoy doing refuels us. Balancing life involves putting things that we value and have passion for in our schedule. Balancing your soul, meditation. Some people find that balance in a quiet space. Some people like to be in a crowded room to feel balanced. Again, knowing who you are and knowing how you react to your internal and external environment, and then within that, finding balance is very important. And then connections, colleagues, therapists, friends, family, supervisors, building a positive support system that supports you, okay? One of the things that when I graduated from my fellowship, one of the things that I was fearful of, that I knew is going to be very stressful is, oh my gosh, I don't have a supervisor to go to. And one thing I did was that when I started my first job in 2011, I emailed one of my supervisors during residency and said, would it be okay if, I seek supervision from you? And, and my teacher said yes, and it was such a relief. That relief that I'm not gonna make this huge mistake. I mean, I was prepared as a new psychiatrist to, have situations that I have not seen before. However, I didn't know if I could, who can I talk to if there is a mistake or there's something I'm not understanding. And that was the biggest relief. So for people who are graduating, for people who are, graduating, moving on to working independently, it's very important to find somebody that you can call, that you can talk to. I still do. Our program director, Dr. Kliss Hulbert, or, there are a couple other faculty members that I feel comfortable talking about my clinical cases if need be. I reach out because ultimately, again, it's about balance. It's about making sure that you're doing your job effectively, but also so I am done. I will be happy to answer questions. I do have some time. So if it's a few minutes to 12, I do have time to stay and answer questions if somebody wants to stay.
Thank you so much, Dr. Shakir. This was wonderful. If anybody has any questions, feel free to unmute. In the meantime, I'm going to drop the post-test evaluation in the chat. For all BWET and OEP students should complete this, as well as anybody looking to get continuing education credits. A lot of thank yous in the chat, Dr. Shakir. Thank you again. This was wonderful, very informative.
Thank you. My pleasure.
For folks who aren't in the BWET or OEP programs and are not looking for continuing education credits, here's a link to the evaluation only. So go ahead and complete this one if you are not part of BWET and OEP and not looking for CEs.
Hey, Eric, I wanted to just make a comment and really thank Dr. Shakir for the wonderful presentation. I'm seeing all the students that are saying how much it helped them, and so I really appreciate your time. I really was very happy that you talked about self-care, and I think as you were talking, it reminded me of how professionals who don't engage in that and often find themselves doing some of those things that you had listed and they do not do. And sometimes getting their license at risk, right? Mm-hmm. Because when they behave in that way, then they get in trouble and then someone files a complaint and then it becomes a huge issue. And I like to remind students of that. It's of course important to self-care for your well-being, but it's also for your professional well-being as well. And so I really appreciate that you included that.
Thank you.